One patient, one position, one doc. Port hopping technique for robotic nephroureterectomy. Following is the case summary of patient who underwent demonstrated surgery.
Hereby is the port arrangement for robotic left nephroureterectomy in right lateral position. Da Vinci X robot was used, pneumoperitoneum created and ports inserted under visual guidance. Line of told, incised, left colon dropped away and retroperitoneum accessed. It is important to differentiate between gyrotous fascia and mesocolon, both having different shades of yellow color. Gonadal vessel and ureter identified by carrying out sharp dissection in retroperitoneum. Ureter is traced upwards till renal hilum is reached, which would further help in gaining control over vascular structures. It is imperative to consciously look for and gain control over lumbar vessel or any major branch coming directly from aorta or renal vessels.
Gonadal vessel dissected, clipped and cut.
Renal vein is most oftenly the interiormost structure in hilum. Hereby, renal hilum is completely dissected, renal vein isolated, ligated using vascular clips and cut. Renal artery is dissected posterior to renal vein, isolated, ligated with vascular clips and cut.
Adrenal gland spared.
Following vascular control, para-aortic and perihilar lymph nodes are dissected. They may be ligated or cauterized, depending on individual preference. Once the kidney and upper ureter are dissected and lymph node dissection completed, robotic port hopping technique can be used as shown in the image. Instruments are shifted to right port and rightmost port. Fourth port instrument is shifted to leftmost port, first port. This helps in saving time, avoiding morbidity of open surgery with improved vision and no compromise in oncological outcome. As seen here, monopolar scissor is shifted to fourth port, camera to third port, bipolar grasper to second port and progress at the first port. This helps in excellent exposure, access, and manipulation of pelvic structures. Then the left lower ureter is dissected all the way down till bladder. Any inadvertent injury to ureter or bladder should strictly be avoided, as it may lead to dismal oncological outcome. Suction and irrigation can be used through assistant ports for better visualization of surgical field.
Medial umbilical ligament forms an important landmark. Ureter runs medial and deep to it.
Lower ureter ligated to prevent any accidental tumor spillage. Day suture taken over bladder wall, which would help in traction and better delineation, eventually leading to increased accuracy at the time of resection. Bladder filled and open. DJ tent was already placed during previous cystoscopy biopsy procedure, which helped in identification of ureteric orifice. Finally, ureter with adequate margin of bladder cuff resected under excellent vision using monopolar scissor. The cut margin of specimen enclosed to prevent any tumor spillage.
Inner layer closed with PDS suture.
Outer layer closed with V-lock suture in running fashion. Ipsilateral pelvic lymph node dissection must be done at the time of nephroureterectomy. Notably, orientation of landmarks may differ in lateral position as opposed to that in supine or low lithotomy position at the time of pelvic lymph node dissection done for other malignancies.
30-degree scope may help in better visualization during pelvic lymph node dissection.
Thus, robotic port hopping technique provides excellent approach to deal with both retroperitoneal as well pelvic structures during nephroureterectomy.
Final histopath was suggestive of high-grade disease with clear margin.